All right. As most of you know, it's been a difficult time, difficult few years to be a patient, but it's also been a difficult few years to be a clinician. With COVID-19 and the apparent erosion of civility in public discourse and the clinician-patient relationship, which has historically been based on open communication and trust, times have become increasingly fraught. And an example of this is the patient who expresses their biases or bigotry in the healthcare setting by demeaning healthcare workers based on their race, sex, ethnicity, or other social identity characteristics. So it can look something like this. Okay. So we have this, okay, so we're opening with a 57-year-old man who arrives in the emergency department late one night with shortness of breath and a fever. A nurse does an initial workup and thinks his condition could be serious, so she goes to get Dr. Jones, the physician on call, to evaluate the patient. When Dr. Jones enters the room, the patient says, "Oh my God, you're finally here. Thank goodness. My TV isn't working. It's driving me nuts. Can you fix it?" Dr. Jones explains that she's his physician, and the patient gets agitated and yells, "I don't want to be treated by any Black doctors. Get this woman out of my room. I want a real doctor." Now, you can fill in the blank with respect to the rejected physician. It could be a Latino doctor, an Asian doctor, a Muslim doctor. Any of these categories could apply. And scenarios such as this are more common than one would think and occur at hospitals throughout the country. In fact, I call it one of medicine's open secrets because you'd be hard pressed to find a clinician, particularly a clinician of color, who hasn't had this experience or who doesn't know someone who has. And what makes these encounters can leave clinicians feeling burnt out and numb after being asked to do so much in such seemingly impossible conditions. And what makes biased patient encounters so challenging is that they raise many thorny legal, clinical, and ethical questions for all the parties involved. And these scenarios are particularly difficult when the patient has capacity but isn't stable enough to be sent elsewhere. So the question then becomes, how do we effectively address this phenomenon? And then how do we do so in a way that balances the interests of patients, providers, and healthcare institutions? So this will be the focus of my talk today. We're going to discuss the different ways that biased patient conduct can manifest. Then we're going to talk about the rights and obligations of those most directly affected when these encounters occur. Then we'll work through some case studies involving patient bias. We're also going to discuss what you can do about it. So we're then going to turn to what an appropriate organizational response might look like. And then I'll conclude by having you work through a few problems based on a few short videos that I'm going to show. But before we can talk about patient bias, we have to have a clear understanding of what it is and what it actually looks like. And these physician-patient encounters can take any number of forms. The following are going to be a few examples of patient bias experiences that occurred or that were experienced by hospitalists, residents, and students at UCSF San Francisco UCSF General Hospital. Their experiences were collected through interviews that form the basis of an article that my co-authors and I published in JAMA entitled "Physician and Trainee Experiences with Patient Bias." So we're going to go through a few of them, beginning with explicit refusals of care. The patient said, "I looked at your name and thought I'd see someone that looked like me. I don't want to talk to you." And she started yelling at us to leave. Then the attending came in and she started yelling at him too, because he was Black. Fourth-year medical student, woman, Latina. The doctor was Sikh, so he had a long beard. The patient demanded, "I don't want to be seen by a Muslim doctor." Fourth-year medical student, man, South Asian. And then he used the N-word. "Out of my view," he said, "I hate you. Don't touch me. I don't like your people." Third-year resident, woman, Latina. There's also explicit or socially biased remarks. Things were escalating and the patient said, basically, "Get the F out of my room, you effing anti-gay slur," to the nurse. And then the nurse walked out and looked really upset. Second-year resident, man. There was a Muslim medical student and she had her scarf on her head, and the patient pointed at her and said, "You, You're the cause of everything that's gone wrong in America. Fourth year medical student, South Asian. There's also questioning the clinician's clinical role. The daughter was asking for a dark-skinned support nurse who'd been following her throughout her hospital stay, and I immediately knew that she was referring to me because I was the intern writing the orders. Third year resident woman, Asian. I'd been working with a female resident, and the patient addresses me as the doctor. And then there's this moment where I say, no, I'm just a medical student. I'd never had it happen with a male resident or a male intern. Fourth year medical student, man, white. Another example is nonverbal disrespect. The patient was sitting in the ER with a lot of swastika tattoos and other offensive tattoos on their body. Hospitalist, man, white. I've been on all female teams, and one situation that I remember is passing a room and having a patient's son whistle at the entire team. Fourth year medical student, woman, Latina. We also have ethnic jokes and stereotypes. He was smiling and said, Syrians, they own a bunch of gas stations. I always joke with them every time they're filling up my gas. Oh, you're going to put an IED on that car? Just totally, he was laughing. Second year resident, man, Syrian. A lot of people think I'm Indian, so I have a lot of experiences when I walk into the patient's room and they'll start asking me about curry and spices, and I'm not Indian. I feel like if they started talking to me about tortillas, beans, that would probably hurt more. Third year resident, woman, Latina. Then there's assertive inquiries into the clinician's ethnic background. I'd say about half the time, maybe 2/3 of the time, I say my name when I introduce myself and I get, what is that? What are you? Second year resident, man, Syrian. I've had patients or their family members look at my last name and start asking me questions like, oh, where are you from? Where are your parents from? Actually, someone even commented, your English is really good. Really? I was born in the US, thank you. Fourth year medical resident, medical student, woman, Latina. And finally, we have contextually inappropriate compliments or flirtatious remarks. I'd say at the VA, someone called me honey at least once a day. Fourth year medical student, woman, white. I'd put them under the large umbrella of sexual harassment or uncomfortable compliments. It's not even sort of the normal greeting, it's occasionally you say, nice earrings. It's more, we're in the middle of an exam and you're commenting on my blouse, and that's weird. Fourth year medical student, gender nonconforming, white. Okay, so that should give you a sense of the range of biased and demeaning patient conduct. But today, we're going to focus on some of the most difficult types of cases, and these are reassignment demands based on the provider's social identity characteristics. And to do this, we need to first identify the groups that are most directly affected when these cases arise, along with their rights and responsibilities. So there are three primary groups that are most directly involved. What do you think they are? I'm going to give you a moment to think about it. They're patients, healthcare providers, and medical institutions. So we're going to go through each one and identify their rights and responsibilities, beginning with patients. Patients have the right to receive stabilizing treatment. This is in keeping with the Emergency Medical Treatment and Active Labor Act, EMTALA. It requires hospitals to screen and stabilize patients if necessary in emergency situations, or to arrange for a transfer with patient consent to a facility able to provide appropriate treatment. Patients also have the right to refuse medical treatment, which includes the right to refuse wanted treatment from an unwanted clinician. This right to refuse is a well-respected legal and ethical principle that's based in informed consent and in laws that protect patients from battery, which is unwanted touching. Many hospitals also have patient Bill of Rights documents that include explicit language about a patient's right to refuse treatment from unwanted providers. For example, here's the Brigham and Women's Hospital's patient Bill of Rights. You'll notice at the bottom that it says, you have a right to refuse to be observed, examined, or treated by students or any other staff without jeopardizing your access to care. All right, so now let's turn to healthcare providers. What are healthcare workers' rights and responsibilities? Well, they have a duty to treat, but they also have employment rights that must be respected. They have a right to a workplace free from certain types of discrimination, including discrimination on the basis of race, sex, ethnicity, and religion. These are considered legally protected classifications. And then their healthcare institutions. What are their interests and obligations? Well, they have to meet EMTALA requirements. And again, this is the federal anti-patient dumping statute. It protects patients from being rejected by hospitals without first being screened and stabilized if necessary. Medical centers also have to protect the employment rights of their workers. So, for example, if a healthcare institution continually forces its clinicians to treat or refrain from treating patients who've rejected them based on their race, sex, or ethnicity or religion, then the healthcare institution could be liable for creating a hostile work environment in violation of employment discrimination laws. Okay, so at this point, you're all probably thinking, all right, I get it. This is pretty straightforward. But it can get murkier the deeper you go. Take healthcare institutions, for example. Are they damned if they do and damned if they don't? If they accommodate the patient's wishes for a doctor of a different race or ethnicity, are they discriminating against the assigned clinician and opening themselves up to legal liability? But if they don't accommodate the patient's demands, will they be violating laws against battery by forcing the patient to be treated by an unwanted doctor without consent? But on the other hand, if they don't screen and stabilize the patient, will they be liable for violating EMTALA? It's complicated. So again, what do you do? There weren't any clear guidelines on how to effectively balance all of these concerns, so my co-authors and I provide guidelines in an article published in the New England Journal of Medicine entitled Dealing with Racist Patients. And prior to that article, I published a lengthier piece in the UCLA Law Review that examined the legal ramifications of accommodating patients' racial preferences in the hospital setting. Now, let's now walk through some of our findings and recommendations. We just discussed in broad strokes the legal landscape for healthcare providers and medical centers, but this discussion didn't answer the threshold normative question of whether medical centers and clinicians should accommodate patients' preferences in this context. So to get at that, let's now turn to patients. The case I opened with is what I imagine many people envision when they think about patients rejecting clinicians based on race or ethnicity, but these cases can also look quite different. Let's review a few more real-world case studies. An elderly Korean patient goes to the hospital with symptoms that suggest congestive heart failure. He's provided treatment that offers a very good chance of success, and he'd likely make a full recovery, and all seems to be going well until one day he says he only wants to be treated by physicians in suits. The staff is puzzled by his request, and it's ultimately denied. The patient then becomes increasingly withdrawn and eventually refuses treatment entirely. The hospital performs a competency test and he's found to have full capacity. So they respect his wishes as they must, and all treatment is stopped. And that would have been the end of it had someone not noticed that he'd filled out a form requesting full resuscitation should he go into cardiopulmonary arrest. When confronted with the seeming contradiction and after some prodding, he asked whether they'd noticed that his treating physicians had all been either Japanese or of Japanese descent. The hospital is in Hawaii, which has a large Japanese American population, and the patient was Korean and elderly and remembered Imperial Japan and said that he didn't trust these physicians and he didn't believe that they had his best interests in mind. And the reason he wanted to be treated by physicians in suits was because he'd noticed that a higher percentage of the non-Japanese American physicians wore suits because they also taught in the medical school. So his request was a sort of a more palatable or sort of more politically correct way of asking for what he wanted. All right, our next case study. Here we have a Black woman. She presents with symptoms that suggest renal failure. And she's fairly uncommunicative with her physicians. She's giving very reluctant yes and no answers to their questions as they try to take her history. And at some point during this process, she sees a doctor, a Black doctor, treating another patient, and she points and says, I want to talk to him. So, why might this patient be making this request? Maybe she's had a prior negative experience with a non Black physician. Maybe she's had a prior positive experience with a Black physician. But maybe it's just bias. At this point, it's unclear. Okay. Here we have a patient who's Latin American. She arrives in the ER with chest pain, and as she's getting her history taken, she declares that she doesn't want the assigned Latinx doctor. She wants an American doctor, which turns out to mean Anglo American physician. So let me ask you a question. How is the patient's request in scenario 3 different from the others? Did anybody catch it? Let me give you a moment to think about it. How is the patient's request in scenario 3 different from the others? Well, she's not so much rejecting a physician as she's asking for race concordance. We see this with women who want a female OBGYN, gender concordance, or Muslim patients who want a culturally or religiously concordant physician. So in this way, this case is a little bit different, but it's still discrimination. Let's go back to case study 2 for a moment, our Korean patient. Clinicians may see a similar version of this among veterans who don't want to be treated by a clinician who reminds them of a former enemy combatant. So perhaps it's bias, but maybe it's PTSD. So we can argue that discrimination is bad, and it often is, but the idea of discrimination gets a bit more complex in the clinical medical context, particularly in emergency situations or situations where you can't simply ask the patient to take the clinician they've been assigned or to just leave. Sometimes the patient's behavior very clearly seems to be based on bigotry or animus, but other times it looks different. So, what might these patients, particularly case studies 2 and 3, what might these patients be looking for? What seems to be underlying their request for a different physician? I'll give you a moment to think about that too. Case studies, particularly case studies 2 and 3, what could these patients be looking for? What could be underlying their request for a different physician? Trust. You all know that trust is an important element of the clinician-patient relationship, and trust is particularly important for patients who are from marginalized or underserved communities. Many studies show that they generally don't have high levels of trust in the healthcare system. And this feeling of mistrust that we see among members of racial and ethnic minority groups isn't just random paranoia. Studies show that members of these groups may have good reason not to trust the healthcare system. Overwhelming evidence shows that racial and ethnic minorities still tend to receive poorer quality healthcare as compared to white Americans, even when factors such as insurance status are controlled. Now, some of this may be due to structural inequality, but research also shows that sadly, there's still racial and ethnic bias in medical practice. So some clinicians, like members of any other profession, may harbor implicit or sometimes explicit biases. And these biases can negatively affect all aspects of the clinical relationship, including clinical decision-making and healthcare outcomes. These biases also contribute to the widespread and well-documented health disparities that we see among racial groups in the United States. But data also shows that for some patients, particularly patients of color, race concordance can counter the effect of clinician implicit bias, discrimination, and stereotyping. And this kind of concordance also tends to promote greater patient trust, communication, and satisfaction. And all of these factors go to the core of the clinician-patient relationship. Now, this doesn't mean that we need to default to race concordant clinician-patient relationships. Instead, all of this is to say that although our first instinct, when we hear about patients' biases and cases of patients making race-based reassignment demands, our first instinct may be that These requests should just be denied to have a zero tolerance approach. But to provide adequate care to all patients, it may be necessary to distinguish between garden variety racism and patients seeking a clinician who they feel can understand their experiences, who will show them respect, and whom they can trust. So the question then becomes, how can this be accomplished? How can you distinguish between both types of reassignment requests? And then how should you respond? To get at this, my co-authors and I devised 5 ethical guidelines to inform clinician decision-making when these cases arise. And since there's no clear legal solution, there needs to be a clinical one. And it can involve, first, considering the patient's medical condition. Second, assessing the patient's decision-making capacity. Third, trying to determine the reason for the request. Fourth, trying to figure out your options for responding. And finally, taking account of the effect on the clinician. And as you go through these guidelines, you should also engage the patient through negotiation, persuasion, and if necessary, accommodation. Now, at the end of my talk, I'm going to have you work through some problems because although this may seem pretty straightforward, it actually requires some unpacking. Take, for example, determining the reason for the request. This can be clinically and ethically significant. So, for example, it can be ethically appropriate to accommodate reassignment requests that seem to be seeking language or cultural concordance. But as we've already discussed, it's not always so clear-cut. We have our first case study, Fix My TV. Well, maybe it's bigotry. Our second case study, no Japanese American doctors. Well, maybe it's PTSD. Our third case study, I don't want the Black doctor. Well, is this patient seeking race or ethnicity concordance? And finally, I want an American doctor. Well, is this a misunderstanding about the doctor's qualifications? As I mentioned, negotiation can be an important tool. So if you're the only physician available, or if you don't want to reallocate patients, then you can try to negotiate with the patient to allow you to provide care. So for the patient in case studies 3 or 4, this type of negotiation could be effective. You'll also notice at the bottom that accommodation is sometimes acceptable. For the patient in case study 2, a Korean patient, this is in fact what the physicians did. The patient then accepted treatment and made a full recovery and went home. And although accommodation is sometimes necessary, it isn't a perfect solution. And this is particularly the case where a patient isn't just requesting concordance, but is explicitly rejecting a provider based on his or her racial or ethnic background. Because this tends to disproportionately and negatively affect providers of color. And each time it happens, it's like another slice of the knife. And for some, the cumulative effect can be significant. As you can imagine, these experiences can be painful and demeaning for the clinician involved. And these experiences can also exact heavy emotional and psychological toll, and all of this contributes to burnout. Take, for example, the recent pediatrics resident who went into the examination room to greet her patient. She introduced herself and she went to give the patient a high five. And as she was doing so, the patient's father, who was in the room, said, "Don't you touch my child. I don't want a Black doctor." Now, even if the resident decides that she doesn't want to continue working with this family, the episode isn't over for her. The emotional and psychological weight of the encounter will linger. So we're in a really patient-centered culture of care, which is important, but we can't forget our first line providers, particularly nurses and trainees. There's a pervasive belief among many in the medical profession that clinicians are supposed to be stoic and just deal with it. It's just part of the job. But first-line providers and other clinicians need to feel supported. So a 2016 study, coincidentally out of Stanford, found that 93% of over 400 first-year residents had experienced disruptive patient behavior, including racial bias. And among these, 50% didn't know how to respond. while 25% believed that nothing would be done if they had alerted hospital leadership. And in my experience, these numbers hold across institutions and even today. Another study found that, another study from the American Nurses Foundation found that 57% of over 1,200 nurses surveyed said that they felt exhausted. 43% said they felt burnt out, and 20% said they felt only 20% said they felt valued. And this was conducted right before COVID, so you can imagine what the numbers are maybe today. And all of this tells us something. It tells us that there isn't enough institutional support for these groups. So when these cases arise, there has to be a formalized process in place. And I'm going to walk you through what that might look like. So these guidelines are from another article that my co-authors and I published in the Annals of Internal Medicine entitled Addressing Patient Bias Towards Healthcare Workers, Recommendations for Medical Centers. And this article goes into more detail than I can get into today, but I'll go through the primary points. First, your medical center has to have a written policy. This may seem obvious, but you'd be surprised by how many medical centers don't have them. So they often have difficult patient policies, but they don't have policies that address how to deal with racist or bigoted patients, even though we know these situations can be more complex, because you can't use a blanket response. Since the patient request may be clinically significant, an accommodation may be warranted. A written policy is important for accomplishing a number of important goals: implementing procedures, clarifying expectations, promoting consistency and adherence to relevant laws, and outlining governing ethical principles, including justice and respect in the healthcare delivery. And it also protects patients and healthcare workers. Now, it's not enough to just have a policy. People need to know about it and about how it's going to be enforced. This policy also needs to account for different clinical roles and services, because a one-size-fits-all policy isn't going to meet the needs of all healthcare workers, because a seasoned physician may have options and need different supports from a junior physician, nurse, or trainee. Plus, the legal consequences of the medical center's actions may differ depending on the clinician's roles. So, for example, clinicians who are employees are covered by federal anti-discrimination laws, but trainees may be covered by Title IX, which covers gender discrimination. The clinical roles matter. And with respect to services, emergency departments and psychiatric department clinicians may need different protocols, because unlike primary care clinicians, emergency department clinicians often work under extreme time constraints, and they don't typically have existing or long-term relationships with their patients. And they may be more likely to encounter patients who are psychologically impaired or intoxicated. And all of this raises unique challenges for addressing patient bias. In concrete terms, what might different protocols look like? Well, let's consider students. Students should be exempted from caring for biased patients until they have the clinical experience necessary to do so effectively. So as a default position, students should have to specifically opt in to treat biased patients. So they should have to make an explicit request to continue caring for the patient. And they should only be able to do so with appropriate supervisory support. Attending physicians and residents, on the other hand, should have to explicitly opt out because they have more experience. Reassignment should only occur at their request or with their explicit permission. Now, back to trainees. When these situations occur, if a supervisor is present, then she should wait a moment to see how the trainee wants to proceed and whether the trainee wants to handle the situation herself. But if not, the supervisor needs to step in and let the patient know that the trainees are qualified to be doing what they're doing and that hateful speech and behavior won't be tolerated. And it's particularly important for the supervisor to model appropriate behavior. If a supervisor isn't present when a bias incident occurs, then the medical center has to make sure that there are clear reporting mechanisms. And I'll say a little bit more about reporting later. After the event, there has to be an opportunity to follow up and debrief because you're giving the affected staff an opportunity to talk about the incident, preferably sitting down one on one with a trusted point person who has debriefing or facilitation skills. And you want to acknowledge the situation and how hurtful it can be, and check in with the clinician about how they're feeling and about how they want to respond. They should also be offered supports and be encouraged to report the incident. And it's also important not to minimize the encounter because all of this is about taking people's difficult experiences seriously and giving them a chance to vent. Now, in addition to debriefing with the rejected provider, the medical center should also address the fact that these encounters can have a corrosive effect on other people who witness them, but who may not know what to do or how to respond. So you may want to have a team meeting. And when I say team meeting, I mean not just the clinicians, but also those on staff or administrators who are in a position to make a difference or institutional change. So during these meetings, those who've had these encounters can share their experiences and discuss what approaches they found useful, what approaches didn't work. And this team meeting is important because total prevention is impossible. So members of the team are probably going to have these experiences at some point in their careers. And if they don't have these experiences directly, they're going to witness somebody else going through it. And by these encounters, I don't just mean rejections based on race, but also based on gender, disability status, religion, gender presentation, or age for that matter. You know, you look too young to be a doctor. I want a more experienced physician. So the team needs to learn the skills to handle these encounters. And now I'm going to give you an example of what it looks like when a team member gets it wrong and then when someone else gets it right. All right, and these are also from our focus group interviews at UCSF Hospital. The patient asked me to join him in bed, and I felt disappointed with the way the attending handled it because he laughed and said, "That's not her job description." The message was that I needed to get over it to take care of the patient. But with another attending, this patient made a similar comment, and this attending said, "We're not going to continue taking care of you if you can't respect our trainees." And I thought, oh, there is a different way to deal with this type of treatment from patients. Fourth year medical student, woman, South Asian. So as I said, everyone needs to learn how to deal with these situations. And if necessary, you can make scripts available and offer training. Another reason to have a team meeting is that some members of the team may have no idea that their colleagues are having these experiences. So bringing these incidents to light also serves as the means of protecting the person who's experienced rejection from internalizing it, because this is more likely to happen if the person feels alone in the experience, or that they won't be supported, or that people will accuse them of being overly sensitive. And this is important because for some providers, this experience could be a macroaggression that comes on the heels of several microaggressions, like constantly being mistaken for the television repair person instead of being recognized as the attending or resident simply because of your race or ethnicity. So supervisors and institutions have to support staff with an eye towards crafting an appropriate future response. This future response can also be based on collected data. Medical centers should track and collect data on these clinician-patient encounters to get baseline information on how often they occur, the institution's response, the ultimate resolution, the effect on the clinician, how affected personnel are supported, and how affected personnel feel about the encounter itself and the institution's response. So the more information your institution has, the better its response will be. And this kind of tracking can be added to an existing system for tracking safety events or other types of patient abuse, or another system can be created. Anonymous reporting or reporting to a DEI office can also be encouraged. Now, in order to be most effective, these institutional responses have to include institutional culture change. As we saw a few years ago with the tide of sexual harassment allegations leading up to the creation of the Me Too and Time's Up movements, many of the people who brought those claims to light worked at institutions that had policies against sexual harassment. But there wasn't a norm of coming forward. Perhaps people didn't feel safe reporting, or they felt that their claims wouldn't be taken seriously, or they felt that their claims might somehow come back to bite them by negatively affecting their career trajectories. Well, the same can be said with respect to healthcare workers dealing with biased patients. Many women and ethnic minorities and LGBTQ participants in our study mentioned concerns about being considered hysterical if they reported. And trainees were particularly worried about worried that reporting would make them appear unprofessional. So as I mentioned, there's an assumption that clinicians must be stoic and just rise above, but these encounters can degrade mental health. So even with the best policies and protocols in place, a culture of non-reporting will undermine meaningful change. So supervisors have to be sensitive to this and work with the medical center to create a norm of reporting and a culture of supporting. Okay, so as I said at the outset, we were going to try a couple hypotheticals based on a few short videos. These videos were created by Karen Smith, and she's the former director of ethics integration at Henry Ford Hospital and Health Systems. And these videos are based on the guidelines that my co-authors and I devised for the New England Journal of Medicine. So they involve nurses, but for our purposes today, we're going to change the clinical roles in each video. So let's say the first will involve a nurse, the second will involve a resident, and the third will involve an attending physician. Now, keep in mind that the people playing the roles in these videos are employees of the hospital. They're not actors, so they're not going to win any Academy Awards for their acting, but these do represent real life cases, and so they are helpful. And as we go through them, I want you to think about what you would do, what you would say, and what concrete steps you would take. Okay, so here we go. I'm going to queue up these videos. Take 1 second. Okay, here we go.
Hi, Mrs. Jones. How is that hip pain doing today? Your surgery is scheduled for 10:30, and I'm here to help get you ready. Do you have any questions for me before we start?
Look, honey, I am not worried about the surgery one bit. What I am worried about is I have not seen not one white American doctor since I've been here. I just don't trust any other doctors.
I'm sorry you feel that way. Dr. Dodge is an excellent orthopedic surgeon. Henry Ford Hospital, we have expert care here.
Nurse, you are not.
I'm stopping because I just queued up the wrong video. I want to show that one last. So give me a moment to.
Dr. Paul-Emile, while you're doing that, we couldn't see the video. We heard the audio, but we couldn't see the video.
Oh, okay. Thanks for letting me know. That is important. Let's try this. Let me do this. Okay.
It's just a black screen.
Yeah. Let me try something else. Okay. Let me see if this works.
Yes.
Okay, you see that one?
Yep.
Okay. So let me start that. And say something if you can't hear it or something else happens.
May I come in?
Finally, somebody listened to my request. I didn't think they were listening over there.
I'm not sure I understand. What is your request?
I only want female caregivers, No men in this room, okay? I told them that at registration. Well, that's what I want, okay? No men in this room. You know what? If a man comes in here, I'm going to get really upset. Are you even listening to me? Kelly? You know what? Better yet, Kelly, give me your manager, or give me the president of this hospital.
Okay, Mr. DoM, I'm only here to help you. Let me go and talk to our unit manager about your request and see what we can do for you. Are you willing to talk to our manager? Is that okay?
Yes. Now, just no more male caregivers.
Sally, we have a problem. Mr. Do doesn't want any male caregivers. He was almost screaming at me, requesting only female caregivers.
Okay, Kelly, I'll go talk to him.
Thank you.
May I come in? Hi, Mr. Doe. I'm Sally, the unit manager. How are you?
Fine, I guess.
Kelly tells me that you're willing to talk to me about your care. Is that right?
Yeah, but like I told Kelly, I only want female caregivers. I mean, how many times do I have to tell people the same thing over and over again?
Okay, I understand you only want female caregivers. We do our best here to accommodate requests, but can you tell me more about your request?
You know, I just can't. I have my reasons why no men should be in this room, and I wish you would just honor that. Please, just honor my request.
Okay, Mr. Doe. We do have excellent female and male caregivers here at Henry Ford, and I want to understand more about your request. Can you tell me more about it?
Yeah, I was molested as a child, okay? Okay? It happened as an early child and through my early adult life. I just can't have men in this room, okay? I'm afraid. I don't want you to tell anybody what I told you. Please don't tell anybody. I just want to have my surgery and go home.
I understand, Mr. Doe. Okay, thank you for telling me. Let me talk to our management and see what we can do to accommodate you, okay?
Okay.
Thank you for your patience. Hi, Mr. Doe. So we've discussed the matter, and we've decided that we can accommodate your request the best we can without compromising your care, okay? While we won't be able to have exclusively female caregivers for you, anytime a male caregiver is in the room, we will have a female present, okay? Does that accommodate your request?
Yes, thank you so much. You have no idea what this means to me.
You're very welcome. Thank you again for sharing that with me. I know that was really traumatic for you. Is there anything else I can do for you? Can I provide you chaplain care?
That would be wonderful. Thank you so much.
You're very welcome.
Finally,
Give me one
somebody
second
listened to
to
my
stop the
request.
video.
I didn't think they were listening over there.
I'm not sure I understand. What is your...
There we go. Okay. Now, let me get my slides back up. Okay. All right. Okay. So you hear, let me start my video. All right, a few technical difficulties. All right, so let's go to our guidelines. In this case, the patient appears stable, but in every case, you have to assess the patient's medical condition, and this should drive clinical decision-making. So in an emergency situation, if the patient is unstable, then she should be treated and stabilized. You should also assess the patient's decision-making capacity, because reassignment requests that seem to be based on bigotry may be due to delirium, dementia, or psychosis, and the patient's preferences may change if he has a reversible disorder that's identified and treated. So you want to make sure the patient isn't cognitively impaired. You then want to try to determine the reason for the request, the reassignment request. And as we saw here, the rationale behind the request can be clinically and ethically significant. Prior trauma, PTSD. So in these cases, it may be ethically appropriate to accommodate the reassignment request. And to get at what's driving the patient's request, you should ask open-ended questions. You can ask the patient to tell you more so that you can better understand his concerns, and acknowledge that these types of conversations are difficult. So you can stress to the patient that the more open he is with you, the better able you'll be to provide the best possible care. Now, this can be very effective if the patient, the discriminatory remark is based on fears or anxieties, but it might not be so successful if you're dealing with animus or bigotry. All right, so I'm now going to turn to our next video. Oh, all right, that's not, no. So I'm gonna try something else. Let's see if this works. Screen share. There we go.
Hello, Mark. My name is Sarah, and I will be your nurse today in the PACU. How are you feeling? Can I get you or your wife some water?
I'm just feeling a bit groggy. Some water will be okay. Thank you.
Just ice for me. What is that you're wearing on your head?
Oh, I'm wearing a hijab. It's a religious garment.
Oh, are you one of those Muslims? Your religion is such a disgrace.
Yes, I am a Muslim. I'm sorry that you feel that way. I'm just going to go grab your water now.
Now hold on a minute.
Margaret, please let it go.
Mark, be quiet. Now, Sarah, have you heard the word of Jesus? I'm going to sit you down and show you these videos that I have that will help you realize why your religion is so backwards and screwed up. Christianity is a more peaceful religion than that Muslim stuff you guys practice. You don't see Christian terrorists ruining the world now, do you?
I'm sorry you feel that way, but I don't think this is a good time to be discussing religion right now. I'll just be back with your water.
You people are so stupid. You don't want to talk about the one true religion with me because you're just brainwashed by your Muslim stuff. You don't actually know what you believe. You know what? I want a different nurse from Mark. I don't trust you with my husband's care.
Okay, I will talk to the nurse manager on staff right now.
Now, in this scenario, imagine that this is a resident. And so you can either put yourself in her position or in the position of her supervisor and think about what you would say and what you would do.
Hey, Diane.
Hi.
Can I speak to you for a minute?
Yes.
My patient's wife, Margaret, in bed number 5, has requested a different caregiver. She's indicated that she doesn't trust me because I'm Muslim. I didn't address religion in any way with the patient or his wife.
I'm sorry that the patient's wife has taken a stance that she does not trust your care based on your religious affiliation. The reassignment of caregivers based solely on this is against our current policy. I will speak with the patient.
Thank you.
Would you be comfortable continuing care if the patient agrees?
Of course, I will do my best to care for him as usual.
Thank you. Hello, Mark. I'm the nurse manager for the post-anesthesia care unit. My name is Diane. Is this your wife?
Yes, it is.
Would you please tell me more about your request for a different nurse?
I don't understand what's wrong with this place. I simply do not want someone who does not believe in the Lord taking care of my husband.
I can assure you that Nurse Sarah will provide the highest level of care to you. It is against our current policy to reassign care providers based upon religious or other personal characteristics. Of course, you do always have the right to transfer to a different facility once you're medically stable to do so.
I'm okay with the nurse I have and will not discuss religion any further. Margaret, please, now is not the time.
Thank you for understanding, and I'm happy that you will continue your care here. But I do have to make it clear that any further discussion regarding religion will be grounds for us to review our current administrative discharge policy.
We understand.
Hi, Sarah. The patient and his wife have agreed not to discuss religion and for you to continue care. I really appreciate your professional demeanor in this very personal matter. Are you okay still with caring for the patient?
Yes, I am.
If anything changes, please just let me know.
Thank you so much for your support.
You're welcome.
Okay, so let's get our slides back up. Okie doke. So notice how the supervisor asked the resident if she would be willing to continue working with the patient. This is important in situations involving racist or biased patients because the responses can have, as I mentioned, legal implications. You also should place limits. Make clear that the patient can't continue to use bigoted or demeaning language or behavior. And whereas here the patient has capacity, she may be open to negotiation or persuasion. So you could explain that all the clinicians on staff are very qualified and the patient's health may be jeopardized by any delay caused by finding another clinician. And while doing this, the physician should also try to establish mutually acceptable expectations for the provision of care. So this wasn't the case here, but in some situations, it may be helpful to enlist a family member to help persuade the patient to accept medical treatment. So now I'm going to show the last video.
Hi, Mrs. Jones. How's that hip pain doing today? Your surgery is scheduled for 10:30, and I'm here to help get you ready. Do you have any questions for me before we start?
Look, honey, I am not worried about the surgery one bit. What I am worried about is I have not seen not one white American doctor since I've been here. I just don't trust any other doctors.
I'm sorry you feel that way. Dr. Dodge is an excellent orthopedic surgeon. Henry Ford Hospital, we have expert care here.
Nurse, you are not listening to me one bit. I only want white American doctors taking care of me. If you can't get me what I want, find somebody who can.
I'll get my manager to speak with you.
Hi, Miss Jones. I'm Keith. I'm the nurse manager. Your nurse tells me that you have some concerns. Can you tell me a bit more about your concerns?
Oh, look, I told the nurse I only want white American doctors caring for me.
Miss Jones, thanks for sharing that with me. Unfortunately, I won't be able to accommodate that type of request. Our policies are clear. You can trust our providers. They're very well trained.
I only want white American doctors caring for me, just like me.
Miss Jones, I am unable to accommodate that request for white American staff only. This is a very diverse hospital. We all work together as a team to provide our patients with the best quality care. At this point, I can offer to transfer you to another facility that could better meet your needs.
If you're such a diverse hospital, why is it such a problem to get me all white American staff?
Mrs. Jones, if you continue to refuse to accept our quality care providers that are assigned to provide for your care, I will attempt to transfer you to another facility that could better meet your needs. Or I will be forced to initiate our administrative discharge procedures.
Get my clothes.
Dr. Paul-Emile, you're on mute.
Thank you. I'm going to wrap up pretty quickly here. So in this in this video, we saw the clinician discuss transfer. So this is an option for stable patients at the attending physician's discretion. Outpatients can be informed of their right to seek treatment elsewhere if they object to a clinician on racial or ethnic grounds. And for inpatients, if they're stable and the request appears to be based on bigotry, then an on-call administrator could inform the patient of her right to seek care elsewhere and her responsibility not to engage in hateful speech. Now, if the patient still fails to comply, then she can be assisted in transferring to another hospital. For patients who aren't stabilized or in an emergency situation, someone else, such as a nurse or a medical resident, could be allowed to do the patient's initial evaluation, but it has to be made clear to the patient that the assigned physician is still responsible and that having someone else perform the physical evaluation is not the standard of care. So in conclusion, I think at this point you have a sense of how you can manage these difficult interactions, and policies and guidelines go a long way in helping patients learn how to navigate these difficult patient encounters, but it's not enough. The medical profession as a whole has to increase diversity among providers beginning in medical school, and also expand cultural awareness at all levels of practice and training, so that clinicians can interact more effectively with various patient populations. And this includes learning how to talk openly and productively about different forms of inequality. But until this happens, what I've laid out is a clinically, ethically, and legally appropriate means of balancing the rights and interests of patients, providers, and healthcare institutions. So thank you.
Thank you so much, Dr. Paul-Emile. We're almost right at time, but we have time for one question. So I'm going to share the question from Dr. Epstein, our colleague Dr. Epstein, who put in the Q&A. He asks, in your research, have you run into any cases of patients expressing seemingly complimentary opinions about healthcare staff based on racial ethnic stereotypes? For example, stating they are glad to have a smart Jewish or smart Asian doctor. I've run into this. I'm not sure how to respond.
Yeah, so I mean, maybe I should add that to our list of the different ways that it can respond. Well, actually, it's the sort of flirtatious or seemingly complimentary remarks. Yeah, that's also a form of demeaning behavior. You know, some people find that there was sometimes, if the person isn't intentionally seeming to be biased and yet it comes off as biased, your response, if you put it sort of in a joke, but it's a hard hitting, you're making your point heard, but in a joke, the patient sometimes gets it without feeling, because they didn't say it from a place of bigotry. So you can say something like, "Oh, what makes you think that, of course we can do, all of our, it's, I'm not just." Well, you get where I'm going. But sometimes if your retort is said with a smile and humor, even though the actual response is hard hitting, it goes through.
Thanks. And then if it's all right, I'll actually piggyback on one more question here from Dr. Lafayette. He asks, in the last video that we saw, there wasn't any assessment of why she felt the way she felt, determining the reason if there was a negative experience in the past. Would that have been an important step in that scenario?
Yes, definitely. Always probe. As I mentioned, you always have to ask, really try to get at what could be driving the request, because as I mentioned, it can be ethically and clinically significant. So of course, you have to ask why, and don't just stop with the first answer they get. Sometimes you can maybe enlist family members to tell you a little bit about the patient's background. You're asking in a respectful way, and with the understanding that these are really difficult conversations for the patient sometimes to have, to open up and talk about their background. But you do want to make those sorts of inquiries.
Okay. Well, we are at time. So thank you so much, Dr. Paul-Emile, for sharing of your time with us and your wisdom. I think you saw the comments in the chat of everyone thanking you for the talk. And thank you, everyone, for your time and attention.
Thank you for the invitation. This was a pleasure to engage with you and your colleagues.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.